Now we come to the real core issue in our course, that is 3-zone, 3-column surgical channeloplasty. And we will be covering it under several headings, but primarily trying to explain to you how we can go through the foramen and tackle all the symptom generating tissues and targets. We already talked about choosing a patient. We'll talk about evaluation, pre-anesthetic checkup, and the symptoms, the consents, the medical comorbidities and its effects, and then how we land for the upper zone towards the upper end plate of the disc, coming below the facet, or how we land on the lower end plate, coming from above under the pars. And then, of course, the adequacy of surgery and keeping a good record of surgery in the form of videos, images, pre and post. Now, when we are talking of all these concepts, we must realize that we are now extending the boundaries of disc surgery to canal surgery, or we are going for the roof and the floor with respect to changes not only in the disc but in the canal. And we are not using the word foraminoplasty, but we are using the word channeloplasty. Now what we do is we make a record, make a mention of the name, age, sex, the BMI and the obesity of the patient. Why? Because it is commonly associated with stenosis at that age. Then the address, the diagnosis, the phone number, the segments involved, 4, 5, 5, 1, the side which is involved, the route which is involved, L5 or S1, and if the presentation is on the side or in the center, or the changes which are on the side or it is more central. Then the comorbidities like diabetes mellitus, ischemic heart disease, knee osteoarthrosis, etc. Admission date, surgery date, discharge date, date of first follow-up, date of follow-up entry. Then the presenting complaints in the form of numbness, etc., the duration, the pain in the lower back or in the leg at rest, unilateral, bilateral, whether it is radicular pain associated with weakness, numbness. If numbness is present even at rest, it may remain as residual and may cause dissatisfaction about the treatment. We note in these 10 questions which have been shown before, numbness and or pain present in the thighs down to the calves and the shins. Numbness and pain increases in intensity after walking for a while but is relieved at rest. Standing for a while brings on numbness and or pain in thighs down to the calves or shins. Numbness and pain reduced by bending forward. Numbness is present in both legs. Numbness is present in soles of both feet. Numbness arises around the buttocks. Numbness is present but pain is absent. A burning sensation arises around the buttocks and walking nearly causes urination. These are increasingly intense symptoms of stenosis, first 2 being mild, first 6 being moderate, first all 10 being severe stenosis. Now neurogenic claudication or neurogenic claudication distance and time has to be noted. The patient with severe intermittent claudication should be carefully followed because there are significant deterioration despite the success in conservative treatment. And the patient may have what is called as grumbling cauda equina syndrome with affection of the bladder function or the bowel function. We need to find out if there is an effect on the symptoms with Valsalva maneuver, that is holding your breath, closing your nose and trying to breathe out. And provocative posture is either extension or flexion. Commonly, if the causes are around facet and posterior to the dural sac, extension commonly causes increased problem. If there is a deformity or change posture, commonly there is a stoop posture and the patient is not able to straighten. We have to know the association of smoking. We have to check the distal pulses, whether we have advised a Doppler study for arterial and venous, both maybe in the lower limbs. And we need to know that in cases of lumbar spinal canal stenosis, feeling of the tibial nerve and compressing and finding out the tenderness of the nerve is a very important test for simple primary level diagnosis of lumbar canal stenosis. Now, we know following things on multiple visits. That is there a relief in the symptoms? Is there an improvement in the deformity? If there is back pain or radicular pain, and the VAS of the pain. Then weakness, numbness, claudication in terms of distance and time, bladder symptoms, bowel symptoms, improvement in other significant findings like knee effusion or swelling of legs. We also do a post-op SF36, a post-op McNabb's criteria outcome is also done, a Bristol stool score, uroflowmetry, max flow rate, post-op uroflowmetry, voided volume, etc. and uroflowmetry curve and post-void residue are done. MRI findings are noted, CT finding including the foraminal area are noted. A post-op intervention may be needed to relieve inflammation and pain in the form of intradiscal steroid, transforaminal steroid, and the interval between the surgery and the need for this injection is also noted. Now, recurrent or new symptoms in the follow-up period are noted, post-op complications are noted, weakness, numbness, new back pain, dysesthesia, radicular pain, bowel bladder symptoms, infection, etc. could be the complications. Now, the first thing which we start with understanding in patients of stenosis is chronic cauda equina syndrome. Let us understand that when we talk of cauda equina, it is almost always thought about as an acute problem. Here we are dealing with chronic cauda equina, and what we see is there is a nocturnal leg cramps, neurogenic bladder bowel symptoms, incomplete bladder emptying, urinary hesitancy, incontinence, nocturia, urinary infections, recurrent erectile dysfunction, and patient may underreport these symptoms, believing them to be a normal consequence of aging. Bladder bowel dysfunction to a high degree may be present. Saddle anesthesia and sexual dysfunction are all multifactorial in their causes, which might include a range of morbidities, pain, and medication side effects, in addition to the spine-related cause. Fluctuation over periods of time and variability related to spinal position and movement is also known. Symptoms may reduce or increase over a period of time, and symptoms may deteriorate over time in less than a third or half of the people with mild to moderate lumbar stenosis symptoms. That is, it is not necessary that they will improve. There may be a very short duration improvement and it may deteriorate further. Erectile function is also known to be affected by age-related pathologies as diabetes, hypertension, and cardiovascular disease. Saddle sensory changes might be caused by a variety of lesions affecting central, autonomic, or peripheral nervous system with increasing age, such as neurodegenerative pathologies or tumors. MRI sensitivity in lumbar stenosis is very high, almost 96%, but specificity may be very low, as low as 68%. And any concerning symptom of bladder bowel lower limb dysfunction should be investigated appropriately if it is not explained by local or other pathologies. So what we are trying to say is that we need to be concentrating on spine-related causes, but we do not lose sight of other causes. When we do ultrasound for post-void residue, the post-void residue cutoff value of 200 ml is a strong predictor of compression, and in suspected cases it has better sensitivity 94%, specificity 72%, negative predictive value of 98%. The area under ROC for cutoff value of 200 ml is 0.81 and indicates that discriminative power of PVR is good, justifying its clinical utility in evaluation of patients with central canal stenosis or central stenosis. Post-void residue more than 200 was the most important predictor of MRI confirmed cauda equina compression. Regression analysis revealed that odds of having cauda equina compressive lesions in MRI is 20 times higher if post-void residue is more than 200. Post-void residue above 200 also had higher sensitivity, specificity and predictive value as compared to only perianal numbness. So what we try to do here is highlight this point that we must do post-void residue in all patients above the age of 65. The second test which we normally advise to the patient is a 6-minute walking test. Now 6-minute walking test or a walking test with a app in your phone where you find out how much you are able to walk is very helpful. So you start walking, you go around the turning point and come back, and then you continue walking. Now since the distance commonly in a building, in our operation theaters, outside the theaters or wards is not more than 100 feet or 30 meters, we use that distance or we use the time of 6 minutes and we measure the number of steps taken. We note that and we see whether it is increasing or decreasing. There is a separate app on the Google Play called a 6-minute walking test app. The second thing which we do is we can also use this peripheral stimulator, which is a part of our conservative treatment, but the same similar gadgets are available for assessing the walking ability of the patient. Now this measuring of walking ability and this gadget which has been shown in this picture, both these are used for conservative care. We use this distal blocker on the back as well as distally on the leg towards the points which were mentioned before, so that the patient is able to experience the change in the walking ability. We can also use oral medication, postural exercises, physical therapy. In some patients calcitonin helps, and use of IV injectable prostaglandins has been reported in the literature, but we have no personal experience about that modality of care. Now we will now go into the anatomy and revision of anatomy of upper, middle and lower zone. Now here in the upper zone is basically the area of the canal which is bound by the body above, the pedicle and the inferior articular process up to this lower end plate line. Now why this lower end plate line? Because the superior articular process shown by this asterisk lies below this line. So everything which is above this line, the body, the pedicle and the inferior articular process and the area which is enclosed by this is called as the upper zone. And what are the pathologies here? The important part is the nerve is situated in the foramen, could be affected like this by overriding superior articular process, pushing it, hypertrophy of the ligamentum flavum here, shown here. And in this picture you can see 3D fusion image which shows the hypertrophied ligamentum flavum pressing on the nerve in the middle and the upper zone, as can be seen here. Now the upper zone has some very important structures apart from the nerve, and we are going to go into details of these structures because it makes sense to understand them, and then you would realize the importance of upper zone decompression in lumbar canal stenosis. The first thing we understand is the sinovertebral nerve, which has been shown by this asterisk. The CR is cranial, D is the disc here, GC is the gray rami communicant of the nerve root, N is the nerve root, as you can see here. P is the pedicle of the vertebra. TP is the transverse process, and this is dura mater. So this is dura, this is the nerve, this is the sinovertebral nerve going to the disc. So this is the nerve supply of the disc, which is very important in understanding the low back pain. This is another picture where this is sinovertebral nerves, this is the nerve root, GC is greater rami communicantus. This is the transverse process, and you can see these are the vessels in the upper part. Now we need to realize that this is a transverse process, this is a vertebral body, this is the disc, and is supplied by this sinovertebral nerves. Further, we have a right lateral view of the intervertebral foramen. We have removed the transverse process, and it shows the sinovertebral nerve. This is the cranial part, this is the disc, this is the greater rami communicantus. The pedicle is here going back like this, and we have the dura, we have the nerve, the sinovertebral nerves. Then we see it in the coronal plane, dorsal view of the foramen, where we have removed the laminae. This is the pedicle, this is the pedicle, this is showing. Now these are also lower pedicles. This is actually the disc. Anything below this lower margin of the disc, down here, this is the lower zone of the lateral rhesus here. This is the middle zone or the disc zone. And everything above this superior end plate here of this disc level is the upper zone. So this is the upper zone. You can see the arteries coming in. This is the sinovertebral nerve, posterocentral branches of the spinal artery are seen. This is cranial part. D is the disc. DM is the dura mater. M is the main trunk branches of the sinovertebral nerve. Here, this M, this is the main trunk branch. N is the nerve root, and P is the cross section of the pedicle of the vertebra. We go further, and where we have removed the dura mater, and now we will see there are sinovertebral nerve, these branches, this is the nerve, greater rami, this is the artery, this is the disc, this is the pedicle, this is the lower pedicle, the pedicle, lower pedicle, and we have to see that everything above this end plate up to the pedicle, this will be the upper zone, the disc area will be the middle zone, everything below this end plate down here will be the lower zone or the lateral rhesus, where the traversing nerve will be situated. Now we have understood from the literature and the animal studies that this axillary area is very important for causation of neurogenic claudication. What happens is this ascending radicular artery, descending radicular artery, there is a zone which is the junctional zone or transition zone, or you can see it here, it is somewhere here. This is the artery going down, artery coming from above, this is the ascending artery, this is the descending artery, and this is the transition zone or watershed zone. So changes occurring here in the form of arterial ischemia and venous drainage getting congested are possibly the causes of claudication. We go further and try to understand the anatomy of the segmental artery. Now this is D12. You can see the origin of the segmental artery from the dorsal aspect of the aorta. This is coming here below the transverse process and the pedicle in the upper part. It gives these branches, and if you see very carefully, this anterior and posterior nerve roots, anterior radiculomedullary artery, that is the dura and the root. This is the radicular artery and prelaminar artery. This is the retrocorporeal arteries, and this is something which will be dorsal branch, and the lumbar artery lateral branch. This will go to the paraspinal area. Now we must remember that this is the neural foramen, and this green thing is the subpedicular approach where sometimes you may have to tackle this artery for various reasons, but you must remember that our surgery occurs here, which is the safest area. Somehow in our talks or in our write-ups, we have not highlighted the point that the upper part of the foramen has the artery. It is very, very important to know that this is where the artery may get compressed and we may have the symptoms of stenosis. Here we have seen what happens with the changes, and we need to know what happens in the upper foramen. Now we go further and we try to study the typical branching pattern of lumbar artery. The lumbar artery branches off from the abdominal aorta. It courses lateral to the corresponding vertebra and usually gives off several branches to the psoas muscle. That is the PB is the psoas muscle branches. P for psoas branches. Then in the extraforaminal region, the lumbar artery divides into two main branches, the dorsal lumbar artery or the DB and the lateral branches, the LB. The lateral branches go to the muscle, the paraspinal area. This DB crosses the spinal nerve and bifurcates into two branches at the aponeurosis of intertransverse muscles, reaching the posterior paravertebral muscles. So this gives two branches, and LB courses slightly caudal to the transverse process, terminates in the wall here. Now vertebral branch diverges from the lumbar artery, this is the vertebral branch, and in the extraforaminal region enters the spinal canal and pierces the mid-posterior part of the body where it supplies the vertebra as a nutrient artery. So here what we see is LA is the lumbar artery, S and B is the spinal nerve root branch, diverges from the dorsal branch, and this is the plexus branch PXB. PXB reaches the confluence of spinal nerves. So it goes in the plexus, that is the plexus branch. Here the LA branches to the spinal nerve. So what we do is, this is the nerve and this is the dura, this is the lumbar artery, this is the dorsal branch, this is the RB is the radicular branch, this is the nerve, and we can go through this. The lumbar artery branches to the spinal nerve. A is the radicular branch, which is shown here, originates from the first lumbar artery, enters the spinal canal, penetrating the nerve near the medial wall of pedicle. Now this is the pedicle and this is the medial wall of pedicle. So you must remember, this is one of the dangerous areas where the radicular branch of the lumbar artery is seen. The SNB is the it is a branch from this dorsal branch and it diverges and reaches the dorsal side of the nerve. PXB, which we have seen before, the branch to the psoas, diverges from the lumbar artery, penetrates the plexus, which was inverted from dorsal side to the ventral side to facilitate easy observation. Now here what we had done is, we had changed it from dorsal to ventral. So DB is a dorsal branch, LA is the lumbar artery, LB is the lateral branch, plexus branch is PXB, spinal nerve, TP is transverse process, and VB is the vertebral branch. Now these other branches will be seen in the next dissection. Here the lumbar artery, which is seen here, left fourth lumbar artery. This is the L3 nerve, this is the L4 nerve forming the plexus, and this LA gives a plexus branch. Now up is cranial and this side is the lateral. This is the transverse process. So let's see, a radicular branch RB. Then we have the SNB and we have the PXB, that is the plexus branch. Now LB is the lateral branch, DB is the dorsal branch, PXB is the plexus branch. What we have to note is that all this is happening just below the pedicle and more ventral in this area, and we are landing on the disc in the lower part of the foramen, and we are safe as we are away from the lumbar radicular branch or the lumbar artery of the spinal nerve related artery. This is again the disc space, and we can see this is the nerve, this is the right second lumbar artery, this is cranial, this is lateral. This is one more dissection which shows the disc, there is the vertebra L4 and left fourth lumbar artery, this is the pedicle, this is the nerve, this is the transverse process, and lateral view of the left fourth lumbar artery and its branches. The fourth artery gives a branch to L5 which corresponds to fifth lumbar artery. Now this fourth artery gives a branch down here for the fifth. So we come back here. Now this demonstrates the origins and frequencies of SNBs and PXBs, that is the branches to the nerves and branches to the psoas. The SNB is lumbar artery 38%, lumbar artery 56%, this is 19%. DB is dorsal branch, LB is the lateral branch, LA is the lumbar artery, LB 19%, DB 19%, LA 56%. What we have to carry home from this dissection related discussion is that our axis, if we land in this part of the foramen just below pedicle, is extremely dangerous because it has all these arteries. Now we talk of 3-column targets zone wise, and when we talk zone wise we have to be very attentive to what we are going to say here. Anteriorly, the causes are mainly in the middle zone, where it is osteophyte at the upper end plate at the disc, lower end plate of the disc, bulging disc with loss of concavity, hardened annulus and chronic non-healing ulcer with a trap fragment. It can also be a herniated disc fragment, untreated, calcified, ossified, collagenized, etc. Middle foraminal tissue knot between the upper end plate and the tip of the SAP that we have talked sometime before, and the posterior causes are ligamentum flavum at the tip of the SAP in the subpars upper zone, under the facet, subfacet, that is more in the middle zone, and ligamentum flavum, facet capsule, etc. at the tip of the IAP in the lower zone, that is the tip of the facet in the lower part of the segment. Now, if we look at this structure, this is the PLL, this is the pedicle, this is the pedicle, this is the pedicle, this is the pedicle, and the PLL as it goes down becomes narrow and is deficient in these corners and the area around. So, it is found that it is much more common to get a herniation here paracentrally rather than centrally, and this herniation can be a small herniation which may be chronic and can give rise to a paracentral osteophyte which is always inside the medial pedicle line. Now here you will see that in this is the upper pedicle, we come below that, then we come further below that is the upper zone where we see clearly, then the middle zone and the lower zone. The lower zone shows this lateral recess, and you have to see this is the body of the vertebra, pedicle of the vertebra. This is SAP beginning, IAP, SAP, IAP are articulated as a facet joint. Ligamentum flavum is from midline up to here, and which may go right up to the upper pedicle from below. So this is the way we see the various zones in the MRI. In the middle zone, what we have to see is we have to confirm that the concavity of the disc is maintained. We have to look at the foraminal area. We have to look also at what is happening to the facet tropism. We have to see that this IAP ends at somewhat mid pedicle. Below this, inside the pedicle, is the lower zone. Here is the middle zone. here is the upper zone. Now here we will see this is pedicle above 5-1, there is the disc, there is asymmetry, there is some changes in the foramen on the right, and there is the lateral races where you see the body of the vertebra, pedicle, and you see that this looks like that Mickey Mouse where the face and these two nerves which are in the lateral races. Now posterior causes are mainly these horns of the ligamentum flavum. As we have talked, the ligamentum flavum is not only interlaminar, but it goes along the facet joint up to the pedicle above, and many times it is deficient in the lower part of the foramen. This is the way the facet tropism can be present, and depending on the lie of the facet, if it is too horizontal, it may give rise to a change in the configuration of these lateral races. If it is too vertical, this will look different. If it is too vertical, this canal would be wider. If it is vertical, since the facet joints are more aligned in the sagittal plane, there will be higher chances of listhesis. If it is too horizontal, they will come in this, they will have a bigger lateral races, they will have a smaller central canal, but there will be less chances of listhesis. Now this is the pedicle, this is the ligamentum flavum, this is the lamina. So we are looking ventrally, we are looking from the front, and we find that the ligamentum flavum comes right up to the pedicle from the midline like this. Now this is the ridge of the facet, this is the lamina, and the posterior midline is far away from the symptom causing axilla. Now a simple point to be understood here is that we need to know the upper part of the foramen is circular, is about 8 mm already, whereas lower part is bone, and we need to cut this, or we need to do oblique pediculectomy as to make this about 8 mm so that we can put our cannula there, and then we can operate and treat our patients more easily, since we have a better control on the movement in the lower zone. In the upper zone anyway, we never go above the nerve, so our surgery is more related to the end plate here and ligamentum flavum and hypertrophic tissue here. But the lower zone, we need to improve the access by doing a foraminoplasty and go for the channelplasty. Then this is a picture where we are trying to show you the view from the front, the ventral. There is a ligamentum flavum, there is a pedicle, and two images have been superimposed as you can see here or here, and you will find that this is the nerve which is coming out, there is a pedicle, the pedicle above, there is a traversing nerve where there is a ridge is there, there is ligamentum flavum in the center, there is a lateral part of the ligamentum flavum, and here you can see very clearly there is the axilla, there is the disc, there is the axilla here, and what we are dealing with is the tissue which is lying here in the roof, which is the ligamentum flavum. Now, a little bit of literature. In the beginning of last century, there were many heterogeneous etiologies. In the second half, the disc degeneration took over almost entire literature about low back pain, and the tendency was to prefer organic visible abnormality as an etiology of the problem, the low back pain and sciatic pain, and an inclination to trust technical diagnostic results more than clinical judgment was present. And there was an over-dominance of disc as a cause of everything, or the ligamentum flavum in the midline posterior as a cause of claudication. It was very simple. Front, the disc; back, the ligament. Spinal nerve roots are devoid of lymphatic vessels, immersed in cerebrospinal fluid within the subarachnoid space. Blood supply of the root depends on the blood flow from peripheral direction and the spinal cord direction. We have seen this ascending and descending arteries next to the nerve roots. There is a watershed of blood stream in the artery itself. Compression and breakdown of blood-brain barrier and disturbance of CSF flow, venous congestion, and presence of intraradicular edema formation is seen in cases of stenosis. Nerve tissue has already degenerated under compression, then gets Wallerian degeneration, giving rise to further symptoms. Then, anatomic details of radicular arteries have been described. There are three groups: distal, proximal, and nutrient arteries. Each spinal root has blood supply, distal, proximal, and anastomosis in the proximal 1/3 of the root. Relative hypovascularity form below the conus by combined areas of anastomosis in the cauda equina may provide an anatomic rationale for the suspected neuroischemic manifestations, with, in addition to, degenerative changes in lumbar spine. The direction of the blood flow is changing. There is a little agreement over which is more essential for claudication. Is it the ischemia or congestion, or it is both? That is still not very well known, because the blood flow is changing all the time, coming from ascending or descending artery. But the important point is the anastomosis of the arteries is in the proximal third of the root, and it is there in the proximal part of the upper foramen, or the upper foramen just below the pedicle, that the cause of claudication is situated. Venous congestion disrupted the blood-nerve barrier. There was extravasation and edema in the nerve root. Blood-nerve barrier that regulates vascular permeability in the nerve root is susceptible to congestion, which raises the intravascular pressure, rather than to ischemia, which decreases the pressure. When there is no feeding by the artery, the pressure reduces. The spinal canal stenosis frequently shows gadolinium enhancement or MR images suggesting that there is a breakdown of blood-nerve barrier and edema of the nerve root. Ectopic firing is elicited by venous stasis in the rat model of lumbar canal stenosis. So here what we are saying is the symptoms in lumbar canal stenosis do not arise from posterior midline cause dorsal to the dural sac, but it arises definitely from the upper part of the foramen and the upper zone. We need to be extremely clear on this point, because this is one important rationale for accessing the stenosis through the foramen in the upper part and decompress the upper part directly, the axilla directly,